Welcome to WPS GHA Contractor Advisory Committee meeting. Today is October 23rd, 2025, and the time is 6 p.m., actually 5 p.m. Central Standard Time. My name is Shayan Shaybani, and I'm the co-chair for the state of Iowa. My specialty is chiropractic. And I'm sure the co-chair for the state of Iowa, my specialty is chiropractic. I will be moderating the meeting with my co-chair, CMD Dr. Juan Shaning. Let me see if I can make my camera work now. Is that going to work? That's much better. Thank you. The purpose of CAC is to present the draft LCDs up for consideration to take comments from the CAC. The public is welcome to attend in listen-only capacity. Just to make a disclosure, per 21st Century Cures Act, your attendance as CAC members at this meeting implies that you consent to public disclosure of your opinion and agree that it may be used and will be clearly identified as your opinion within the purpose or final draft LCDs discussed. If CAC member does not consent, please disconnect now. The meeting is being recorded and transcribed. Let me give instruction to the participant now. To aid in transcription, before you make any comments, please state your name and any conflict of interest you may have, or state that there are none. Individuals wishing to comment may click on the raised hand icon or press *5 if you're attending by telephone. When Mr. Staley calls on you, please make sure that your microphone is on at your end and that your speakers are silenced to prevent an echo. CAC members should follow up with verbal comments in writing at Medicare Policy Comments at WPSIC.com. Let's begin discussing the draft LCDs. I'm going to go ahead and hand the meeting over to CMD, Dr. Shaning. Dr. Shaning, please go ahead.
Thank you, Dr. Shivani. Thank you, appreciate it. Let's start that. We host this CAC engagement meeting in both jurisdictions, J5 and J8, to promote communication between the medical administrative contractor, WPS, and our healthcare community. As stated, the CAC advises us, and we preview proposed local coverage determinations during the open period, and we include the summary of the CAC's member recommendation with the final LCDs. So we will now start going over our proposed LCDs for today's meeting. For today's meeting, we have 4 proposed LCD. I will start with a proposed LCD DL40300. This is a new policy that will eventually replace an existing policy. This proposed LCD is peripheral nerve blocks. Its comment period started on September 25, 2025, and will end on November 8, 2025. The lead CMD for WPS of this multi-MAC LCD is Dr. Campos, and the policy coordinator is Michelle Macari. So now, this being said, let's go to a presentation from Dr. Campos, and after Dr. Campos, Dr. Jody Sengstock, our podiatry representative for Michigan and a co-chair for Michigan, for Michigan, is going to give a formal presentation also on this LCD. So after this, please, Dr. Campos, go ahead with your presentation.
Thank you, Dr. Shaning. Rich, perfect. Good afternoon, everyone. As Dr. Shaning stated, this peripheral nerve blocks and procedures for chronic pain, DL40300, is a multi-MAC collaborative policy and includes WPS, CGS, NGS, Noridian, and Palmetto. The LCD reviews the evidence for peripheral nerve blocks and other procedures by condition and establishes limited coverage or non-coverage based on the available evidence. Evidence was synthesized using GRADE methodology and summarized in the overall conclusion section of the tables for each condition within the LCD. A CAC meeting was held on February 3rd, 2025, and the areas in which the policy agreed and disagreed with the SMEs are summarized in the LCD. Next slide. So the LCD utilizes a threshold of at least moderate certainty evidence for coverage consideration. The very low certainty ratings across comparisons indicate substantial uncertainty about the true effectiveness of these minimally invasive interventions, and as a result, any observed effects may not translate into meaningful benefits for patients. The balance of review findings indicates that the use of related minimally invasive interventions for the treatment of chronic non-cancer pain is currently not supported by high-quality evidence. Peripheral nerve blocks, RFAs, and cryoneurolysis, when compared to current standard of care therapies, did not demonstrate consistent sustained improvements in pain, function, patient experience measures, and medication usage by a clinically significant margin. Next slide. Next. Thank you. So this LCD will replace nerve blocks for peripheral neuropathy, L352222, that has been effective since 10/1/2015. The current policy that we have is non-coverage. This policy expands coverage to allow for 3 conditions in which evidence demonstrates that peripheral nerve blocks and procedures provide benefit, and other conditions remain non-covered. Next slide, please. So the first condition that we cover is trigeminal neuralgia. So neurofrequency neurolysis is considered medically reasonable and necessary for the treatment of trigeminal neuralgia when all the following are met. Condition has been present for at least 6 months, and the patient has been non-responsive to medical therapy or intolerant to medical therapy, and the patient is not a good surgical candidate or declines surgical intervention and has had 75% improvement at least after a diagnostic trigeminal nerve block. There is a frequency limitation of 2 radiofrequency treatments within a rolling 12 months. Next slide. The next condition that we cover is carpal tunnel syndrome, or median neuropathy at the wrist. Corticosteroid with or without local anesthetic injection may be used for the treatment of carpal tunnel syndrome. Peripheral nerve blocks with local anesthetics only for the treatment of CTS are not medically reasonable and necessary, and therefore non-covered. And peripheral nerve denervation for CTS is not reasonable and necessary, and therefore not covered. There is a frequency limitation of a maximum of 3 steroid injections for carpal tunnel syndrome per lifetime per side. Next slide. The third condition that we cover is Morton's neuroma. A corticosteroid injection may be used for the treatment of Morton's neuroma with a frequency limitation of 2 steroid injections per lifetime per side. Next, please. So some of the limitations for peripheral nerve blocks and procedures are the typical not needing to use moderate or deep sedation or general anesthesia, doing multiple procedures during the session of peripheral nerve blocks, and using injections of biological or any other injections other than corticosteroids and local anesthetic. Next slide. Other limitations are widespread diffuse pain, systemic polyneuropathies are also not medically necessary. Dry needling is not covered, and it's not routinely necessary for multiple injections or denervation to be provided to a patient on the same day as peripheral nerve procedures. If performed, the medical necessity of each procedure must be clearly documented in the medical record. Next slide, please. And this is a list of procedures and peripheral nerve blocks that are non-covered. Next slide, please. With some exceptions. So regional anesthetic blocks, acute surgical pain, and pain related to malignancy refractory to medical management are not covered in this LCD. Thank you all for your time.
Thank you, Dr. Campos. So now, before I present the next presenter, I want to remind that the comments that will be given today will not be addressed individually, but will be compiled and addressed in a response to comment document when the final LCDs are posted. Having clarified this, let's go to the next presenter. That is our esteemed CAC member, Dr. Jody Sengstock. She's representing podiatry from Michigan, and she's one of our co-chairs. She's going to give a formal presentation on this LCD. So, Dr. Sengstock, please go ahead with your presentation.
I would like to thank everyone for the opportunity to speak and give comments regarding the peripheral nerve block LCD. My name is Dr. Jody Sengstock, and I am the CAC representative for podiatry from the state of Michigan. I represent the Michigan Podiatric Medical Association, which represents 2/3 of practicing DPMs. Next slide, please. As we all know, the 21st Century Cures Act established clear expectations for how federal health policy should integrate real-world evidence, meaning data drawn from actual patient experiences and outcomes, not just tightly controlled clinical trials. Congress directed federal agencies, including the FDA and CMS, to use data from registries, observational studies, claims, and patient-centered outcomes research to inform decision-making. The principle is simple but important. Policy must be rooted in science, reflecting how care is delivered and experienced in the real world. The proposed LCD acknowledges that corticosteroid injections are an accepted, evidence-based surgical treatment for Morton's neuroma. We feel that this is consistent with the medical literature, which supports steroid injections as a first-line or intermediate therapy before surgery and describes injections as a reasonable and effective conservative option, often providing symptom relief and helping patients avoid or delay surgery. Next, please. So we agree with this portion of the policy, recognizing steroid injections as a covered medically necessary service, which aligns with both clinical practice and scientific evidence. We did a review of current research and found multiple systematic reviews and clinical studies that demonstrate that corticosteroid injections are an effective, evidence-based, non-surgical treatment for Morton's neuroma. Next, please. There's an example of a couple of studies. Next, please, Richard. And the next study. And all of these studies collectively show that steroid injections can relieve pain, improve function, delay, and many times prevent the need for surgery in many patients. It is important to note that the literature also reflects real-world variability in how injections are administered, including number of injections, timing, and combination with local anesthetic. but it consistently supports injections as a reasonable conservative therapy when clinically indicated. The next question is whether the proposed lifetime limit on these injections is equally supported by evidence. We do not believe that the review of the literature supports this. Instead, interestingly, many of the authors call for additional high-quality research to determine the optimal number, frequency, and long-term effects of injections, recognizing that protocols vary in real-world practice. I did want to spend a moment on the most recent review that was done in 2024 by Milan Silva et al. This systematic review is a current analysis of infiltrative, non-surgical treatments for Morton's neuroma. It synthesized data from 12 studies, including both randomized trials and longitudinal observational designs covering more than 1,400 patients. This study underscores that infiltrative treatments are safe, well tolerated, and clinically effective, making them a key part of evidence-based conservative care. Crucially, the paper again provides no evidence to support a lifetime limit on corticosteroid injections. Instead, it reinforces that treatment should be guided by patient response, safety considerations, and clinical judgment. Taken together with the earlier reviews, this most recent analysis confirms that the science consistently supports the use of steroid injections for Morton's neuroma, but does not justify the proposed 2 injections per side per lifetime policy restriction, but in fact calls on the need for more research. The takeaway here is that corticosteroid injections are well supported by the literature, while the proposed 2 injections per lifetime per side limit is not. We believe that this LCD proposal goes beyond what the science supports and restricts physicians' ability to tailor care to individual patient needs. It would cap coverage at 2 corticosteroid injections per lifetime per foot, regardless of clinical response, patient characteristics, or disease course. This is a major departure from current practice, where treatment decisions are individualized based on patient outcomes, comorbidities, and tolerance. The current conservative treatments for Morton's neuroma are orthotics, footwear adjustments, and steroid injections. Orthotics are not a covered benefit for many Medicare patients and can be cost prohibitive. Currently, I have the option to give, for example, 1 or 2 injections a year to patients that are not surgical candidates or choose not to have surgery, offering them medium-term relief that allows them to remain active, which we all know is important in this age group. The LCD as proposed would take away that option. Lastly, I believe it forces my Medicare patients into surgery, even if they don't really want surgery, in order to get relief. Their choice would essentially be have surgery or live with the pain. Neuroma surgery has a failure rate of 3 to 8% and is caused by the formation of a stump neuroma, even though surgical techniques were taken to avoid that regrowth. Now the patient would be forced into another surgery to remove that stump neuroma, which can then regrow a 3rd time in patients. Again, I would not be able to offer occasional steroid injections to give them relief in this new LCD proposal. Enough about Morton's neuroma. I would like to briefly discuss another peripheral nerve block. Next slide, please. The proposed LCD explicitly lists posterior tibial nerve block at the tarsal tunnel among procedures considered not reasonable and necessary for chronic pain. Next slide, please. This is a blanket exclusion grouped with other unrelated procedures, we believe, with no scientific rationale or citation specific to the tarsal tunnel. By categorically denying this coverage, the LCD removes a clinically validated, low-risk treatment option that can provide pain relief or delay surgery in select patients. Again, it is also an option for patients in this population that may not be surgical candidates, or for reoccurrence in patients that have had a decompression procedure, which I see in my patients due to diseases such as chronic venous insufficiency. We believe that the literature supports that therapeutic peripheral nerve block at the tarsal tunnel can be an effective conservative treatment option for patients with tarsal tunnel syndrome. These are a couple of the studies. Next one, please. One more time. I would like to, actually one more time, I think, Richard. Yeah. I would like to highlight one of these studies that we reviewed. Can you go back one? Thank you. This study by CAC and colleagues, 2022, is one of the largest analyses of ultrasound-guided corticosteroid injections for tarsal tunnel syndrome with 218 patients. The following injection, 77.5% of patients did not require surgery, indicating that therapeutic peripheral nerve blocks can provide substantial, lasting symptom relief for many individuals. Both surgical and non-surgical groups experienced similar reductions in pain with a mean decrease of roughly 3.6 to 3.8 points and a 0 to 10 scale, confirming consistent benefit from the injection itself. The authors explicitly concluded that steroid injection can be an effective conservative treatment option for patients with tarsal tunnel syndrome. No significant complications were reported, reinforcing that tibial nerve blocks are safe, low cost, and clinically valuable when performed appropriately. Last slide, please. In review, our asks are, first, we strongly support maintaining the LCD language that recognizes corticosteroid injection as a reasonable and necessary treatment for Morton's neuroma. Secondly, we respectfully request that the proposed lifetime limit of 2 injections per side be removed. A rigid lifetime cap would contradict the evidence and restrict clinical judgment without improving safety or outcomes. And third, we urge inclusion of the therapeutic posterior tibial nerve block at the tarsal tunnel as a covered inclusion. Coverage would be criteria-based, not excluded outright, allowing use when conservative therapy fails and diagnostic evaluation supports the indication. This change would align with the LCD with CMS's own 21st Century Cures Act framework, ensuring policy decisions remain grounded in science and real-world clinical practice. Again, thank you for the opportunity to make these comments, and Richard, thank you for your help.
Yeah, thank you, Dr. Sengstad, for your presentation and for your commitment to our Medicare beneficiaries. Now I will open for any additional comments from my fellow CMDs before I ask for comments from other CAC members. So any comments from my fellow CMDs? Okay, hearing none. Are there any comments from any other CAC member on this LCD? Dr. Dooley?
Yes, John Dooley. I'm a practicing pain management physician out of Iowa. There's a couple of problems that I have with this LCD. The major one being that it seems that the criteria for rejecting peripheral nerve blocks was therapeutic effect. But in real life, a lot of times practitioners use these peripheral nerve blocks to make diagnoses, to try to track down where pain may be coming from as a target, a discrete anatomic target, which if that target is in the distribution of a peripheral nerve, useful clinical information might be obtained. I see no discussion of that in any of the literature that is stated there. And in fact, it seems to be even inconsistent with what the policy does allow, which is in the case of a trigeminal nerve radiofrequency or ablation, that you think it's okay to do a diagnostic nerve block ahead of time, and that they have to have 75% improvement in order to go on to the ablation procedure. So on the one hand, that seems to be okay to use a peripheral nerve block for diagnostic purposes. to guide institution of a therapeutic procedure, but only in that circumstance and not in other circumstances listed. I think that's erroneous thinking and not intellectually rigorous. The other thing that bothers me about this is that there seems to be an exception made for malignant pain that has not responded to conservative management. That is also intellectually bereft, because I would challenge anyone who makes the judgment that pain from malignancy is somehow different than chronic pain from a different source, and therefore both need to be treated differently, does not stand up to rigorous examination. The fact that chronic pain occurs and can severely debilitate patients in a non-malignant state is no different than what malignancy can do. The other aspect of that is that malignancy is is used very generically here. Is that malignancy that is active, is in remission, is we don't know whether it's active or in remission? It's entirely inconsistent. And I think that the directors need to understand that when clinicians see these types of inconsistencies in your policies, it really damages your credibility in putting this out as a justification for restricting their practice in trying to help patients in chronic pain. Thank you.
Thank you for your comment, Dr. Dooley. Please, all the commenters, we appreciate your verbal comments, but it's really helpful if you put your verbal comments in writing to our policy comments at wpsic.com mailbox, okay? So thank you for your comments. The next commenter is Dr. Ben Norstrop. Dr. Norstrop, go ahead with your comments, please.
Yes, thank you for letting me in here. So first off, I agree with the presentation from Dr. Sengstock before, very excellent, especially concerning Morton's neuroma. We do quite a few injections for these, and one of the issues that this brings up is the if not this, then what question. And in some patients, the answer to that question is indeed surgery, but in some patients, it cannot be surgery. Some patients are simply not surgical candidates, and they will not be able to, after they get their allotted 2 steroid injections, move on to a surgical therapy. Is the evidence perfect for solving the pain of a Morton's neuroma forever? Absolutely not. But if the patient is not a surgical candidate, they have no other option other than to get continued steroid injections to relieve that pain. So to take that away, I think is a little bit concerning, especially when the evidence does not support that, as Dr. Sengstock so nicely laid out in her presentation. Also, coming back to what Dr. Dooley said, yeah, that's a very important point concerning how some of these are not always used for treatment. The goal is not always long-term relief, but the diagnostic portion to make sure that one can then go on to a different procedure such as radiofrequency ablation. This is seen most commonly with genicular nerve ablation, which I do have a few comments on that specifically as well. So in that case, again, this is another question of if not this, then what? Many of these patients are either not candidates for a knee arthroplasty, or they might have already had a knee arthroplasty and have chronic synovitis causing quite a bit of pain. There's really no other way to treat those patients other than this, or possibly genicular artery embolization. However, the evidence shows that those are effective in different situations. So having both tools at your disposal is very important. Going through some of the evidence, particularly some studies that were not cited in the draft LCD. There's a study from Davis et al., Regional Anesthesia Pain Medicine 2018, comparing genicular nerve RFA versus corticosteroid injection. Again, these are patients who are not surgical candidates, and it did show that genicular nerve RFA demonstrated significantly better pain scores, both NRS scores, Oxford knee score, as well as global perceived effect, and decreased pain medication use. Single study, of course, so let's make it a little bit bigger. A few years later, there was a systematic review of genicular nerve ablation, 33 studies, including 13 randomized control studies. All of these, when taken as a systematic review, showed improved pain function and quality of life at many different markers between 3 and 12 months. Not as long as we had liked. They certainly didn't follow it out quite that long, but I'm sure there will be future studies that give more of a long-term view on that. Again, would we like it to last longer? Absolutely, but the patients might not have that choice. Either they cannot get surgery or they might already have had surgery, and this is a chronic synovitis issue. So in that case, you do the procedure again after 12 months, 2 years, whatever it happens to be when the pain is returning. The other thing, very, very low complication rates with this procedure. Another option, so of course, Medicare spending is a concern to all of us, no doubt. So then another question, particularly with this procedure, is it cost effective? So we've got 2 studies on that, both from Desai in BMC musculoskeletal disorders in 2019 and 2022, comparing genicular nerve RFA to corticosteroid injection and hyaluronic acid injection. So they use the typically accepted United States threshold of $100,000 per quality adjusted life year, and showed that in both cases, genicular nerve RFA is highly cost effective when compared to these 2 other treatments. Again, these are patients who are not candidates for arthroplasty. So that's a rundown of those. There's certainly quite a bit of evidence on many of the other procedures, but I don't want to take up all the time. I know we have other draft LCDs and other people who are wishing to speak, so I'll leave it there, and additional comments I will certainly add. In addition to those, I will add some additional comments in the written at a later date before November 8th. But any questions, I'm happy to discuss.
Thank you. Are there any questions from my fellow CMDs to the comments? Hearing none, Dr. Nordstrom, thank you so much for your comments. They're greatly appreciated. The literature that you mentioned that was not included on the current bibliography of the evidence review done by the multi-MAC committee that work on this LCD. We will appreciate that in addition to your comments, if you could submit that additional literature that you stated was not part of our current bibliography, that would be extremely helpful. So thank you for your comments again and for your service to our CAC and to our beneficiaries.
Absolutely. I will submit those soon. I'll get those in the next few days, and then the other portion might be a little longer, so it might take longer, but the ones I mentioned tonight, I will get to you very soon.
Thank you. Greatly appreciated again, So are there any comments on this LCD before we move to the other 3?
Just a reminder to those of you on the telephone, you can press *5 to raise your hand, and I will unmute your mics as appropriate. All right, I see no raised hands.
So thank you, Rich. And so let's move forward then. And our next LCDs, there are 3 MolDX LCDs. All of these LCDs, our lead CMD is Dr. Nachowski. I'm going to mention the 3 LCDs and let her present on them after I mention them. The first LCD is a new LCD. Is DL40272. Is MolDX biomarker testing for risk stratification in metabolic dysfunction associated steatotic liver disease, metabolic dysfunction associated steatohepatitis. This LCD, the comment period is open from August 28 to 2025. to October 31, 2025. As I previously stated, our lead CMD is Dr. Nachowski, and the policy coordinator is Tara Schroeder. The other LCD that we will be discussing today from MODEX is DL40274, also a new LCD. This is in genetic testing for hereditary thrombophilia. The comment period of this LCD started on September 25, 2025, and is up for comment until November 8, 2025. Again, Dr. Nachowski is our lead CMD, and Andrea King is our policy coordinator for this LCD. And the final MODEX LCD that we will be discussing today is the DL40278. That's also a new LCD, has the same comment period from 9/25/2025 to November 8, 2025. And this LCD is a non-next generation sequencing targeted molecular panel test for predictive testing in cancer. Our policy coordinator for this LCD is Tara Schroeder, and now I will give the meeting to Dr. Nachowski that will be briefly presenting on these three LCDs. Go ahead, Dr. Nachowski, with your presentations.
Thank you so much, Dr. Shaning. From the start, I just again, representing all the CMDs, I'd like to thank all the participants here today. We truly do appreciate your comments. Your presentations were wonderful. And just know that we are here with you to try to create the best policy that we can for our beneficiaries, supported with current medical literature and within the realms of the CMS guidance. We truly appreciate you at the forefront for us. You are the ones that are there for us, seeing the patients real live. And so we appreciate your expertise and all the work that you do so that our beneficiaries can get the appropriate care. And with that, I'm now going to proceed. So I have 3 MODEX policies to present. I just want to give a very brief description of what is the MODEX program in case people don't understand what it is. The molecular diagnostic program, it is a multi-jurisdictional, multi-MAC program. It's composed of multiple MACs that research and develop policy that is related to molecular diagnostic test and complex proteomics. This program is under CMS regulation and guidance. This program has CMDs with multiple specialties and specialty training. It also includes clinical pathologists, PhDs in molecular and clinical genetics, etc., where we all collaborate in policy development. All of the participating MACs will adopt the same finalized policy with the same content and title of the LCD, except the MACs will have a different LCD ID number. Just so that you kind of get the feeling that, okay, we're all in the same picture. My first one, as Dr. Shanin alluded to, is DL40272. The biomarker testing for risk stratification in metabolic dysfunction-associated steatotic liver disease and metabolic dysfunction-associated steatohepatitis. At the end of the meeting, I'm gonna have people that I'm gonna pick and say they have to say that title 10 times quickly and see how we can all get through this. As again, the open comment period was from August 28th, 2025 and closes on October 31st, 2025. This policy describes coverage. So it is a coverage policy for molecular or proteomic biomarker test for the diagnosis and the management of liver fibrosis in the setting of, I'm just going to call it MASLD, which stands for metabolic dysfunction associated steatotic liver disease, And then MASH or MASH, which is for metabolic dysfunction associated steatohepatitis. In accordance with the American Association for the Study of Liver Disease guidance, the term MASLD will be used as a replacement for non-alcoholic fatty liver disease, which is NAFLD, and MASH is the replacement for non-alcoholic steatohepatitis or NASH. As comparisons have found a near complete overlap between the recently defined MASLD population and the historical NAFLD population, results from biomarker validation studies among patients with NAFLD and NASH will be considered applicable to the patients with MASLD and MASH. Other types of chronic liver disease included, but not limited to metabolic dysfunction and alcohol-associated liver disease, meaning MET-ALD. Other chronic liver disease such as alcohol-associated liver disease, viral hepatitis, and autoimmune hepatitis, they are considered separate entities with distinct etiologies, natural histories, and management, and therefore they're not going to be encompassed under this policy. So criteria for coverage for this policy is that all of the following criteria are met. Number one, the patient is an adult with clinical suspicion or diagnosis of MASLD or MASH based on current professional society guidelines, such as the American Gastroenterology Association or the American Association of Clinical Endocrinologists. These guidelines, a second criteria is a primary risk assessment based on non-molecular proteomic laboratory testing as outlined by these consensus guidelines. Does not indicate that these are low-risk patients. Criteria number 3, liver stiffness measurement, or LSM, by imaging. And such imagings could include vibration-controlled transient elastography or magnetic resonance elastography. These measurements are indeterminate or not performed. Criteria number 4 is the results of the test will be used to directly aid in pending management decisions. Example, are you going to refer them to a specialist? Will you perform a liver biopsy? Are they eligible for pharmacological therapy? As documented in the patient's medical record. Testing is not, criteria number 5, testing is not performed more than once within a 12-month period, nor within 12 months following a liver biopsy. The other criteria, such as clinical validity, does the test follow an algorithm? They must follow a technical assessment by the molecular diagnostic program. Those are pretty much established for all of our molecular policies, but the first 5 that I stated were more important for the coverage criteria. At this point, does anybody have any questions or comments? Or no, Dr. Schoening, please advise how you'd like to carry this out. Do you want me to state all 3 policies and then open it afterwards for anyone to make comments on all 3? It's however you'd like to guide us.
I would defer to you. If you want to open it now, since you already asked, it's fine. You know, I would defer to you.
Okay. Does anyone have any questions with this one?
Star 5 to raise your hand on a touch-tone phone. I see no raised hands at this time.
Thanks so much, Rich. Okay, let's go to our next one. DL 40274, molecular MolDX genetic testing for hereditary thrombophilia. This does have a different open comment period from the first one. It's from 9/25/2025 until November 8th, and the last policy will also have this time. Coverage indications, limitations, or medical necessity. This policy, again, is a coverage policy. It's coverage for lab-developed tests, FDA cleared or FDA approved clinical laboratory tests for hereditary thrombophilia, including next generation sequence test. This policy scope is specific for hereditary germline testing. The criteria for coverage for this is all of the following must be met. Number one is that the patient presents with venous thromboembolism or VTE, and at least one of the following is true. The patient presents with VTE that is associated with a non-surgical major transient or hormonal risk factor, as defined by the American Society of Hematology guidelines, or the patient is presenting with cerebral or splenic venous thrombosis in settings where short-term primary treatment is the standard of care, so settings where anticoagulation would otherwise be discontinued, and testing will inform or help us with the decision for long-term anticoagulation. That's the first criteria. Second is genetic testing will guide VTE clinical management, specifically the duration of anticoagulation therapy. Number three, the test performed includes at least the minimum genetic content. That means genes or genetic variants with definitive or well-established guideline-based evidence as determined by the American Society of Hematology, required for clinical decision-making for its intended use that can be reasonably be detected by this test. A single variant test may be used if it's the only variant considered to be reasonable and necessary for a patient given that is a known familiar variant. The test criteria number 4 is the test does not include additional genetic content that is not properly validated or of unclear clinical validity or utility, such that there could be reasonable expectation of misutilization by the patient or treating physician, resulting in impaired patient outcomes. And that is all for the coverage for that. Does anybody have any questions? I guess I'm going to go with this route. Is there any questions in regards to this coverage policy?
Star 5 to raise your hand from a touch-tone phone. And I see no questions at this time or comments.
Okay, thank you, Richard. Our last MODEX policy is DL 40278, which is non-next generation sequencing targeted molecular panel test for predictive testing in cancer. Right. This policy describes, it's a coverage policy for molecular or proteomic panel test for non-next generation sequence targeted molecular panel test for predictive testing in cancer. The determination outlines the medical necessity, limitations, and required documentation for biomarker testing to ensure appropriate patient selection and effective utilization. Criteria for coverage for this. All of the following must be met. Number 1, the patient has a diagnosis of cancer for which molecular testing of the tumor will inform some form of treatment. Number 2, at least one of the following is true. Testing by next generation sequencing is not feasible or will likely fail based on the specimen type or the tumor content. NGS or next generation sequencing is not required by national consensus guidelines to inform medical management decision, and testing by non-next generation sequencing method will provide a rapid result that allows for the prompt and timely management of the patient. So this would be a much more efficient way than the NGS. The test accurately identifies known, common, and necessary predictive and actionable biomarkers that can safely preclude unnecessary NGS testing, reduce NGS use in patients for whom the treatment plan would not likely be altered. Criteria number 3, the patient has not been previously treated by a molecular panel test for the same cancer indication for the same genetic content. Number 4, the test accurately detects the most common genes and genomic positions required for the identification of clinically relevant FDA-approved therapies with a comparison diagnostic biomarker for the given cancer type. And with that, does anybody have any comments in regards to this coverage policy? Hearing nothing, I will take that as a no, that there aren't any. But if you should, at the end of this meeting, please do not hesitate to provide written comments and supply it to the, oh gee, help me out here, Rich, where we send it to, or Dr.
Medicare.
Shane. Okay.
Medicare policy comments at WPSIC.com.
Thank you so
That's
much.
Medicare policy comments at WPSIC.com.
Thank you so much for helping me out there. At this point, I have concluded my 3 policies that are up. Once again, thank you all for taking time out of your busy day to listen to these policies, and any of your comments will be greatly appreciated.
Thank you, Dr. Nashowski, for your presentations. So since there are currently no comments on these 3 policies, we can now move to the members-only portion. So I will be now deferring to Dr. Shevani, our co-chair. So go ahead, Dr. Shevani.
And I'm sorry, Dr. Shivani, before you go ahead, I just want to make sure I let anyone know who is not a CAC member, you may disconnect now. If you are on the telephone and you are a CAC member, please press *5 so I know not to hang up your phone. Thank you.
I don't think we can hear Dr. Shabani. You may have to unmute.
As usual,
good.
my challenges with technology.
I'm just keeping you on track, dear.
Thank you so much. This concludes the presentation and discussion of the draft LCDs. I'd like to thank the public for attending, and you may disconnect now. After a moment, we will continue the CAC members only portion of the meeting, where we will address contractor updates, projects, and provider engagements. Let's give a pause so admin assistant can confirm the public has been disconnected. Richard, has the public left the meeting?